So this year marks the 10th anniversary of BPJS, a program that has significantly reshaped the healthcare landscape in Indonesia by addressing the affordability issues. 276.5 million. That's the number of Indonesians that are now under the coverage of BPJS, making it one of the largest healthcare programs on the planet today, with 98.19% coverage rate. So my first question, Professor Ghufron, as someone who has been at the forefront of BPJS, could you please share with us some of your proudest achievements of BPJS over the years?
Okay, Michael, I think first of all, I would like to thank to you and all the panelists, ladies and gentlemen. Actually, I would like to congratulate for Pak Iing, who the Association Private Hospital Indonesia, who already participate in this very important event. As you know that in Indonesia, now already achieve 98% more of the population. So allow me to, have a video, if you allow us, that just around 10 days ago, we got M.Sc award from ISA. ISA is International Social Security Association, which 162 member states in the globe and give Indonesia as the Universal Health Coverage Award. Okay.
All right, let's watch the video then.
And there are many countries now come to see that is the testimony.
The command center, I found the command center also something that is remarkable for me. That it helps you to get a feel of what is happening on the ground and then how it is being used also to drive the movement and all. I think I'm highly impressed. Yeah.
So to come back to Indonesia and to see BPJS now and what it's achieved is really quite impressive. So I congratulate everyone who's worked on BPJS. It's amazing to see the level of coverage across the country and to see the attention to equity and meeting the needs of the population. And I think I'm still learning about BPJS, but what I can say is I am impressed with how much it is innovating and testing and experimenting with new things. To me, the things that are most exciting are the things that make healthcare different for the individual. So making access easier, bringing services closer to the individual or to the community. I think the ways that BPJS is innovating and finding ways to do that, that's what impresses me most.
Impressive. So the coverage that BPJS has is something that many countries aspire to achieve. So in many ways, it's a place that we can look to learn and see what's being done here that we might be able to transfer and use in other parts of the world that are not as far along in different aspects of health. The integration between levels of the health system and from providers to BPJS is something that's really stood out. So the way that the technology has been used and information is shared to provide better care for the population is something that's been really impressive, and I'm excited to learn more about.
I was very impressed by the digital transformation, and I can't imagine how they handled 1 million insurance claims a day. So I was very impressed by how efficient the leadership, how efficient the management of everything was.
So I think Indonesia's experience with JKN has not only been aspirational, but it's also been inspirational to a lot of countries which come from the same context, low and middle income countries that are aiming to achieve universal health coverage. The experience that Indonesia has had provides invaluable lessons to many countries that are on the same path, which Indonesia has almost achieved near universal, decreasing out-of-pocket expenditures, improving service delivery quality, as well as improving efficiency. So I think the world is looking towards Indonesia for your country experiences and how we can go back and emulate the same in our country.
BPJS keren.
BPJS Kesehatan keren.
BPJS Kesehatan keren.
Okay, please give applause that now we already achieved universal health coverage. And not only that, actually all the countries who come to our office we know exactly the behavior of more than 3,000 hospitals across the country and more than 23,000 clinics and primary healthcare facilities. Not only the behavior, but also, one or each doctor who operate a day, how many of operation, we know exactly. So with more than, like from Mongol, just now, testimony that he or she was confused, cannot imagine how to claim more than 1 million claims a day. And this is successful. I think not only that, but now they can also just online queuing system from home, from coffee shop, or from any places. Not only that, but they also can have medical record in the hand of the patient from corner of Indonesia to other corner, and the doctors will be beneficial and know of it. I think that is all. And of course, if you would like to know more, please come and I will explain it. And you can also look at the web of BPJS Kesehatan. And in Indonesia, we work together with Ministry of Health, but BPJS Kesehatan is not under Minister of Health. It is directly under the President of Republic of Indonesia. That is a little bit different maybe. I think that is all, Michael, and thank you very much.
Thank you, Professor Ghufron. I'll harken back to the funding side shortly with you with one more question.
Sure.
So while the issues of affordability has been largely addressed by BPJS,
right,
the issues of accessibility still remains.
Right. Okay, yeah, of course.
So this next question is for Aristo.
Okay, so not for me?
Not, the question is for you at the very end.
Okay.
Yes. So Aristo, I've had the privilege of working with you and the MOH on a few of the collaboration initiatives. With your close involvement on the ministry's endeavor to transform the healthcare services, can you share with us your perspective on how the MOH is working to increase the quality of healthcare services, especially in terms of accessibility?
Thank you. Thank you, Prof. Ghufron. As you know, the demand in Indonesia is significant, and the challenge has always been the access. So the access, in order for every one of you to start a hospital, definitely the number one thing is availability of doctor. So if you look at some of the largest country in the world, such as India and China, the development of healthcare in their country actually significantly above Indonesia, and primarily because of the availability of doctor. For the demand of healthcare to become a transaction, to become a service, the demand needs to meet with the supply, and then the supply, the provider needs the key ingredient, which is the doctor. And then that has become the front and center of the policy and the implementation being done by Ministry of Health. As you know, recently the regulation, which is PP number 28, has been issued in terms of hospital-based education, in terms of allowing foreign doctor to practice in Indonesia. And then those are the things that we believe in the next years to come will increase the availability of doctor. Currently, there's only 2,700 specialists graduating in this country every year. And by allowing the hospital to become the medium of education, this will go up year by year. We will start with 6 hospitals, then after that 12 hospitals, then roll out more hospitals, so that in the near term, we can have additional 100 to 500 specialists being generated every year in this country. And when the availability of doctor becomes much accessible, we believe we will be able to crack the problem of accessibility in Indonesia.
Thank you, Bob. So when you focus on increasing healthcare accessibility with the strategies that you just described, what are the exact changes we can anticipate in terms of how the country address the catastrophic disease that put such a huge burden on the healthcare cost in the past?
That's a very good question. In Indonesia, there are 4 catastrophic diseases, which is cardiac, cancer, stroke, and uronephrology. And to have early detection and prevention, it's actually very important. We have established the program that in Indonesian word, we call it KJSU. So these are the program, the National Healthcare Program on 4 catastrophic diseases that we create end-to-end from the point of detection, which is being held at Puskesmas. Puskesmas is essentially community health center across 10,000 locations in Indonesia. And then from there, the detection will happen and we will create multiple hub and spoke. To the city, there are 514 cities, then multiple hub and spoke to the provincial capital. There are 34 of that. Then after that, going to the national level, which is hospital being owned by Ministry of Health. So, for instance, with this in cardiology, we will install ECG across 10,000 locations, being funded by the soft loan that the Indonesian government got from World Bank. And then from there, it will create detection. And in the 514 cities, we will install cath lab. And then after that, for a more complex thoracic surgery, it will happen at the provincial capital and also at the national level at the vertical hospital. So that is an example at how Ministry of Health take care cardiology, and there's a similar approach for cancer, stroke, and uronephrology. As you know, 95% cancer case is actually curable as long as there's early detection. And we would like to aim to solve this by having early detection and also have prevention by empowering the Puskesmas across 10,000 locations in Indonesia.
Thank you, Aristo. What you just described is a great program, and you also highlights in your responses the central role of technological enabler to roll out this plan. So my next question, Pak Setiaji, as the MOH CTO, could you please share some of the key initiatives from this technological enabler point of view to facilitate such impressive but also massive KJSU program?
Yeah, good. Okay, thank you. Good morning. Before I explain more about how the technology facilitated this KJSU, or maybe we can talk this CCSU, I will explain more about our agenda. We call this health system transformations. We have 6 pillars or agenda to improve first about the primary cares, to address the health promotive preventions, and then the second about the referral system, and then also we address the resiliency of the health in Indonesia, and then another thing is about the finance within the BPJS, and then the fifth is about the health workers, and then the last about the health technology. In the health technology, we address the 2 issues. We already have the demographic databases. It's coming from the Ministry of Home Affairs. And then we want to develop the second databases. We call this the clinical databases or medical records in the national medical records. And then the third databases is coming from the genomic databases. Because of that, we developed the platform. We call this the Satu Sehat. The Satu Sehat integrated not only BPJS but also from all the health facility, from the BPJS insurance and also from the private insurance. Until now, we already connect more than 36,000 health facility. So the databases medical records, not only from the text but also from the images, is coming from the MRI, etc. It's coming now from to the national medical records. And then I will explain more about the CCSU programs. Yeah, as you know, we have some issue about the follow-up. If the people diagnosis from the CCSU, not only the cancer, after they already diagnosed for the cancers, and then we cannot follow up. Sometimes people is gone, and then they do some things, a treatment, for example, like herbal and etc. and then we don't know about the effectiveness, the treatment for the cancer and etc. Because of that, it's very important thing we develop the databases or cancer CCSU registry. Currently, we already have the standards, and then implement to all the hospital to make sure all the data from every hospital we can recognize all these people are already diagnosed, and then after this we do the treatment follow up to the people. So everyone is diagnosed not only the cancers, also the cardiologists, strokes, and urinary flow. So automatically they're included in our national program, the CCSU. So the data will tell us how many people already diagnosed, and then how many people already got the treatment. And then the important things is information can build the plan. The plan, not only the plan of the treatment, and then the plan of how to make sure the people going well rather than worse. And then the important thing also to develop the more capacity for the health workers, also put in some new technology in the futures to make sure our Indonesia more healthy.
Thank you, Bob. But I'd like to harken back to the issue that we discussed earlier, which is the accessibility of healthcare resources, especially healthcare workers, right? So we know that one of the emblematic issue here is the uneven distribution of doctors. So, Setiaji, from your point of view, how do you think technology can help us address the issue of the uneven distribution of doctors?
Yeah, thank you. Yeah, as you know, from the Aristo said before, about we have some issue about the ratio, the number or ratio of the doctors in Indonesia. If we use the conventional method to develop the new doctors, it needs a long time. Maybe we need 10 years. Because of that, the technology is the fastest way to fill this gap. Yeah, in our blueprints, we set up a new initiative. We call this engagement or improving the telemedicines. So we with the partners within the many startups in Indonesia to make sure the telemedicines can use in the futures. Not only the technology, but the important thing, the regulations. Because of that, last year, we already done the sandbox regulations to make sure the telemedicine can use in Indonesia, not only by the health facility, but also for the IT innovations, or digital innovators. And from the result for sandbox regulatory, already have title or supervised from the Ministry of Health more than 8 innovators. And then we will launch the new regulations for the telemedicines. And then also in the futures, we looking out how the telesurgery in Indonesia can be implemented. Because of that, it's very important thing. We with the BPJS now currently to finalize the unit cost for the telemedicine. So the telemedicine like a startup, like a health facility can get the benefit also from the telemedicine to fulfill the gap for the health workers. We also provide this data into our dashboard so you can see how the distribution in the health sector in Indonesia. Thank you.
Thank you, Bob. So with the increase of access, I'm pretty sure more people will use BPJS. And the reimbursement BPJS will need to shoulder is anticipated. So, Prof, as you have the responsibility to keep the balance of budget of BPJS,
sure.
If I may ask, how does the BPJS plan to maintain the balance of budget?
Okay, before answering your question to maintain the balance of the budget, please allow me just to read the pantun.
Yes.
Di seberang lautan matahari terbit, menerangi jalan yang semua orang bisa melihatnya. Selamat datang teman-teman di manajemen rumah sakit. Mari berbagi pengetahuan kita yang kaya dan tanpa biaya. In English, across the sea, the sun does rise, lighting the path for all to see. Welcome, friend, both smart and wise. Let's share our knowledge, smart and free. Jalan-jalan ke Nusa Dua, jangan lupa makan ayam betutu. Melalui Hospital Management Asia untuk layanan kesehatan yang semakin bermutu. Okay, I think there are many strategies or exit strategies how to handle to make our balance. It is the first time in the history of Indonesia that BPJS is no more deficit. Previously, we were deficit, and then we owe to many hospitals. And private hospital reluctant to work, collaborate with BPJS Kesehatan. But now, private hospital, around 65% of all hospital in Indonesia who contracted to the BPJS is private. Okay, please give applause to Pak Iing with the Indonesia Association Private Hospitals. And then we pay the down payment. So before verification, we pay the money. And all the process should not more than 15 days, 2 weeks, so we have to pay to the hospital. So hospital has money. And we together with Minister of Health increase the tariff. And for the capitation, it is the first time in the history. Not only that, but now we are trying not only online, queuing system, which they can wait only 2 hours or 2.5 hours maybe, previously 6 hours. Not only that, now we are trying to maybe thinking about adjustment of the premium. This is number one. Number two, of course, we work together with private, so public-private partnership and financing is important to have coordination of benefit, but we have to look at the optimum where all the parties are win. So should be win-win solution, not win-lose. That is number two. Number three, so of course rationalization of tariff should not, one tariff should be higher than expected and not fair compared to other procedure, for example. That is number three. Number four, actually now in Indonesia, because we are comprehensively our coverage and without cost sharing. So maybe in the future, we will introduce the cost sharing because many countries in the world introduce cost sharing. Not only that, of course now we are pay attention on the promotion and prevention. Just using very cost-effective way where our beneficiaries can only answering 47 questions through the what we call it history-taking screening. So by doing this, we can classify our population, our beneficiaries to be high risk, medium risk, and low risk. Who has high risk, for example, diabetes mellitus, then we ask them to examine their, blood glucose status to the clinic. Then not only that, we now with Ministry of Health together 14 screening type of screening prevention. We would like to have that gradually. And not only that, of course, we are now to make changes of our behavior, especially in BPJS responsible for personal health, not the public health, personal health. For personal health, like Pak Setiaji already mentioned, for the heart disease, stroke, and cancer, so we are trying to educate the people together and then control it. If they are controlled in hospital to make me more efficient, we will return back to the clinic or the primary health care. And of course, in Indonesia, the way we have strategic and very good strategic is we implementing what we call it managed care system, that people cannot go to hospital directly, but they have to go to the primary health care first. And if the gatekeeper doctor in primary health care see that this person need to be referred to the hospital, then refer to hospital. And the way to pay to the clinic, we use what we call it performance-based capitation. And the hospital, we use not fee for service, but what we are implementing is using prospective payment system in our CBGs. That is all, and thank you very much. I think 5 minutes.
Thank you, Prof. That's very clear. I think to conclude our panel, for now, if I may to summarize, with the right transformation policy in place, strengthened by technological advancement on the supply side, and the continued balance of funding of BPJS supporting the demand side, I'm confident the audience will agree with me that Indonesia's healthcare sector will not only continue to grow, but to do so with an even stronger momentum.
We hope so.
The transformation journey is just getting started, and beyond economics, surely I think what we will see is a healthier and stronger Indonesia. Thank you.
We hope so. Thank you very much.